Hi, my name's Jason Hooper, and we're here with John Brissom.
Hope y'all are doing well.
Today, we're going to talk about inflammatory bowel disease. All right. So, the two biggest pathophysiology of inflammatory bowel disease is Crohn's disease and ulcerative colitis. And I don't think, does anything else get lumped in?
Hashimoto's thyroiditis
Okay.
and colorectal cancer.
Well, those are associated with
Yes.
IBD, but what I'm saying is, are there any other pathophysiologies that are associated with IBD?
No, outside of those two, no.
Okay, so basically you've got Crohn's disease and you've got ulcerative colitis, and that's it.
Yes.
All right, so we should probably start by talking about the difference between the two pathophysiologies and what makes each one different and yet still considered to be inflammatory bowel disease.
Okay, so you want to start with ulcerative colitis?
Yeah.
Okay, so ulcerative colitis is a long-term chronic condition that results in inflammation and ulcers generally found within the colon and the rectum. It is not systemic like Crohn's disease is, and it usually only affects those general areas. Now, there are rare chances where it can cause like megacolon or joint inflammation and stuff like that, but it's usually not seen like it is with Crohn's disease, which has a more systemic manifestation in its disease.
Yeah, and I just want to point out really quickly that megacolon is not as cool as it sounds. You actually don't want that.
No, not at all. Because when you're dealing with megacolon, your colon starts to become very enlarged and starts having a lot of paralysis with the peristalsis for the migrating motor complex. And
yes.
You have to have parts of your colon removed because of that. And sometimes it can be caused by bacterial toxins, which is, of course, toxic megacolon can trigger it too as well. But yeah, ulcerative colitis symptoms usually are found in the colon and the rectum, where Crohn's disease symptoms are generally found in the ileum within the small intestine. Sometimes it can be found in both the ileum and the colon, but usually it is found within the ileum of the small intestine is classic presentation of Crohn's within the digestive tract. But it can also, like I mentioned earlier, become more systemic as far as its symptoms are concerned, which would be like joint pain. Some people get canker sores within their mouth, which is common with Crohn's disease, or inflammation of the eye, usually the white part of the eye, like the sclera, or you might get photophobia from it too, or uveitis. So yes, that's usually associated with it. Hashimoto's thyroiditis is usually associated with it too. But yes, Crohn's disease tends to be more systemic, where ulcerative colitis seems to be mainly inflammation that sticks with the rectum and the colon. And also Crohn's disease can also lead to diseases like B12 deficiency or precocious anemia, or even anemia from lack of iron or from bleeding. But both diseases can cause reduction of iron, but not so much as it's associated with Crohn's disease.
Why is it that there is a higher rate of bile duct involvement in ulcerative colitis rather than Crohn's disease?
Actually, I saw that Crohn's disease could also affect it too, because it affects the ileum. There's a decrease of bile resorption in the ileum. So Crohn's disease, I thought, was usually more associated with gallstones compared to ulcerative colitis. I thought it was actually the reverse.
Okay. The research I read says that there's just a higher rate of bile duct involvement with ulcerative colitis rather than Crohn's disease. But specifically,
my guess is it's just the map. Technically, you can have both conditions, and there are people who have been diagnosed with both. And since it is caused by Mycobacterium Avium Paratuberculosis, both conditions can have issues that manifest themselves in the same areas. People that you see, they rarely have eye issues like uveitis or iritis. They rarely have bile duct issues. You see that more with Crohn's disease, but since it's caused by the same bacteria, both diseases can manifest themselves in the same ways.
Yeah, I think they're primarily referring to just sclerosing cholangitis, like not gallstones and stuff. So that's what I think that they mean by, like, symptomatically there's a higher rate of sclerosing cholangitis with ulcerative colitis rather than Crohn's disease. Sorry, I should have been more clear.
Yeah, it's probably a possibility. I think that it's just the bacteria. When we talk about genes, genes probably have a lot to do with the way it's manifest, and Mycobacterium they do live are able to infect macrophages, and greatly increase TNF alpha when we talk about TNF alpha blockers later. Foreign biological agents to tackle the disease, but yeah, that it doesn't pretty much. The diseases usually have distinct areas, and that could be, when we talk about MAP, there could be different reasons of why that may be, but they can cause almost the exact same symptoms between the two diseases in some people.
All right. Since you brought up the microbiology, I think we should probably get into the cause of inflammatory bowel disease. Well, I guess I don't know if you would consider it the primary or the secondary cause, because you could argue that genetics are the primary cause.
Yeah, but you could also argue that it's not, because some of the studies show that even people without the genes, if they get dosed, genetic mutations, if they get dosed with enough MAP, you can still trigger the disease.
Okay.
That was something I came across in my research. But people with certain gene mutations, which we'll talk about after we talk about the proposed cause, are more likely to get it. Now, I do think the main cause, and there are co-infections associated with ulcerative colitis and Crohn's disease, but I think the main cause of it is Mycobacterium avium paratuberculosis, which is a bacteria that is found in ruminant animals. As their primary host, they cause a condition known as Johne's disease, which manifests itself very similar to ulcerative colitis and Crohn's disease in cattle, where they have similar symptoms
and birds
and birds too, but more likely cattle. This is the specific subspecies that affects humans. But yes, it causes their intestines to form ulcers, bleeding, malnutrition, a lot of common symptoms that you see with people who suffer from inflammatory bowel disease. And that was discovered by a veterinarian in the early 1900s named, I think his name was Wolfgang Johne. But yes, there was a very similar in its presentation between ruminant animals and human beings. And it has actually been known since there was a correlation since the 80s, but they were saying that it was unlikely. But it wasn't till really the early 2010 area, 2009, where it was really started to look at through multiple studies as probably being the single main cause of the disease. And there's many different exposure rates of MAP that we can talk about. One being water, because the bacteria is very hardy. It's able to form thick biofilms and survive chlorine. Where chlorine kind of eliminates a lot of pathogens that would be its pathogens that would stand in its way, that would be its adversary. So a lot of MAP ingestion that we may get within our modern world is from our municipal water supplies being contaminated and not being filtered properly, or if you live near a farm, runoff from cattle feces could contain MAP. And it could get into your water table, and that could end up causing you to get a good dose of the bacteria. But it's more than just ingesting dairy products from ruminant animals, which is another entry method of the bacteria, because pretty much it lives in dairy and it lives in animal feces. So for example, if you slaughter an animal that's suffering from an overgrowth of MAP, and you improperly slaughter and you get the intestines and the feces all over the meat, then that could be another vector, because MAP is able to survive standard cooking temperatures. It's able to survive pasteurization. Heck, it can survive freezing an ice cream for up to a year. So it's very, very hardy.
Yeah, I don't think though you've got to be a really, really stupid butcher to cut into the intestine.
But it happens a lot at the Cargill plants. That's why they have recalls.
Yeah, that's true. I've processed a number of animals in my day. I've never once perforated the intestines. Anyway, I don't know. That's just a little side rant, I guess. MAP can get in. MAP can be systemic, and it can easily get into the muscle tissue. And so, if you eat a steak, or you eat some wild game, like a wild duck or something like that, you could easily get it just from that. Not sure about the eggs though. Like I don't think like if you ate duck eggs, I doubt it would be in there.
Yeah. And we talk about diet later of how you can reduce your MAP exposure and things you can do.
Yeah,
We'll definitely talk about that. But yeah, I mean, it seems that pretty much someone, since it lives in ruminant animals and also poultry to some degree, even though the reactions to poultry might be different actually than the reactions to ruminant animals because they seem to be different subspecies that cause the disease. So pretty much you would agree with me that if you have MAP, you want to filter your water and give up ruminant animal products
sure.
and
Yeah.
meat possibly
Well,
indefinitely.
I mean, you definitely have more experience with this than I do because you've coached a lot more people with Crohn's and ulcerative colitis, and you know what happens when they don't follow the guidelines. So
Yeah, I mean even
I think
even
the proof is kind of in the
even my
pudding.
local gastroenterologist who wrote a book called Cure Constipation Now, Dr. Wesley Jones, he makes a correlation between IBD patients that eat dairy and how awful
Mm,
they are from that, even though he doesn't know about MAP. But even he can see it within his
yeah.
own clinical practice of it happening.
Well, I don't. I don't think nobody has all the answers. I mean, there are 136 alleles that can increase your susceptibility that are known, and I have studied this to the best of my ability, and I still don't entirely understand how it works. But there seems to be a subnetwork of genes that express interleukin 10, which is part of the immune
Mm-hmm.
system. It's like how we fight disease. And there's also like card 9 is a class of genes that's been really implemented in IBD,
And card
and
15
also
too.
yeah, and the that subset as well. And then the expression of HGK is the gene that's supposed to be reducing inflammation that seems to get messed up. And like all of the like you have like these networks of genes and gene expression where they tend to work together, and then any kind of hiccup in there can cause problems. If you have a polymorphism or in one of those genes, you have an enzyme that's not working properly or something, then you're more susceptible to having damage done to your intestinal tract from MAP, from that bacteria.
Yeah, I mean the genes. It seems to affect the macrophages' ability to properly eliminate MAP, so that they can continue to replicate within the macrophages. So the mutations
Mhm.
seem to have an issue also with reduction of TNF alpha, which a lot of the biological agents do, because once a macrophage becomes infected with MAP, it greatly increases TNF alpha, which of course greatly increases inflammation as an inflammatory cytokine. So a lot of the genes pretty much mutations in them seem to weaken a person's immune system to be able to properly both recognize the MAP as a potential pathogen, as long as reducing of inflammation or overactive of the immune system once MAP becomes a stable colony within the digestive tract. But just like I mentioned earlier, though, that's not always the case. You can also not have those certain gene mutations that we'd mentioned, either if it's card 15 or NOD2, any of those, you could be completely normal and still end up having a susceptibility to MAP, depending on the dosage that is given to you and depending on the state of your microbiome and the immune system of your digestive tract.
Yeah, for sure. There are some complications that can arise, even though the disease hasn't really progressed to its fullest state. But you can start to see other things. Celiac disease is particularly associated with inflammatory bowel disease. I don't know. I mean, there are cases. Obviously, I don't know. Like a lot of people have been diagnosed with celiac disease that don't have inflammatory bowel disease,
Yes, like
but
me.
I think I think like a lot of people are getting perhaps even misdiagnosed with that as well. So it's kind of hard to fully correlate that. But it seems that if you have IBD, you're more likely to have celiac disease as like a side effect.
Yeah, and I've heard it because of HLA-DQ2 being associated with both conditions, genetic mutations in HLA-DQA2, making you both more prone to ulcerative colitis and Crohn's disease, and having celiac disease as well.
The other interesting side effect is a lot of times if people start getting inflammation, they start taking non-steroidal anti-inflammatory drugs. That's a huge complication with IBD. They start taking that and they have a lot of problems. So probably should stay away from like ibuprofen, Tylenol, especially aspirin.
Well, I mean, one of the proposed recommendations, if you want to talk about the medicines real quick that are used to treat inflammatory bowel disease, I mean, they use corticosteroids. They use 5-ASA, which is a salicylic acid derivative, and they use biological agents
which is interesting because it's like a derivative of salicylic acid, but it doesn't seem to cause the same amount of bleeding and stuff, you know?
No, but especially when taken as a suppository, but taking orally, it does have it has, immune suppression type side effects associated with it, and lupus, drug-induced lupus, Stevens-Johnson syndrome. It can't have problems, but it seems that using it as suppository, it reduces those risks. But all it does, like any of these drugs, whether it's a biological agent to block TNF alpha, or if it's a corticosteroid to reduce inflammation and to increase cortisol, none of them are reducing the amount of MAP that's within your body or helping your microbiome in any means. All it's doing is just reducing the inflammation. Therefore, you feel better because you have less inflammation. But most people who get on these drugs, they eventually have relapses into the disease. They don't permanently stay in remission. I mean, they did make better drugs like Entericort, which they're using as a local oral corticosteroid that mainly works in the small intestine for Crohn's disease. And isn't supposed to be systemic because 90% of the drug is inactivated before it ever reaches systemic circulation. That seems to be better. And if you are having a very severe flare up, sometimes it is necessary. I mean, you would probably agree with me, Jason, that if there's a choice between having surgery or taking Entericort because you have a major flare up, your best bet would probably take Entericort. But that being said, all these drugs, all they're doing is just suppressing your immune system's reaction to MAP or to other organisms that have been associated with both diseases, whether it's E. coli or Candida or Yersinia or Listeria. These are all co-infections or bacteria that work in symbiosis with MAP. So yeah, all those drugs are doing is just, they're just moving the goalpost.
Well, yeah, I mean, short-term usage of prednisone or methotrexate, I think, might be needed because if the inflammation gets too great and the damage too severe, then they have to start taking stuff out. Because what happens is, I don't think that's good. Not everybody agrees with me, and I'll explain the counter argument in a second. But the issue is once the inflammation becomes too great, it starts to constrict the blood vessels, and when the blood vessels constrict, then the tissues around start to necrotize and die. And so, once that starts to happen, I would say, it's best to remove the necrotizing tissue rather than to leave it in the body and rot, because that's going to lead to sepsis and potentially death. So you're going to have to get that out of there. But like if you preemptively remove it, like some people do, that's kind of like if you went to the doctor and said, "Hey doctor, I have a broken arm," and doctor says, "Well, I have an immediate cure for you. You don't have to have any surgery, or you don't have to wait 6 weeks to recover from this injury. What we're going to do is amputate the arm, and you're not going to have an arm anymore, so no more broken arm," right? And so like that's actually one of the treatments that they do for ulcerative colitis is they just remove the colon, and they're like, it's 100% success rate.
Or they do that if you have the genes for breast cancer, and instead of modulating estrogen or anything like that, just go ahead and remove your breasts as a preventative measure. It's the same nonsense.
Well, some of the, some of the phenotypes are non-estrogen specific though with the breast cancers. But I mean, I don't know. Like to me, I mean, I'm not going to weigh in on the breast cancer issue right now, but just talking about ulcerative colitis, and now, we're going to remove your entire colon. That seems a little severe to me. Maybe try some other methods first, even if they don't know about the dietary benefits. I guess that how certain dietary restrictions could really be a game
Yeah,
changer.
we'll get to that when we start talking about what you can do if you're suffering from IBD. But yeah,
Mm.
I mean, why? My question to any doctors would be, or medical professionals would be, the only drugs that you like, we know through most of the research that more than likely inflammatory bowel disease is not a quote unquote autoimmune condition, where most autoimmune conditions doctors look at or medical professionals look at, the body starts attacking itself and there's no unknown reason. We know there's a known reason more than likely for these conditions. It's Mycobacterium Avium Paratuberculosis. So if you work on reducing the amount of colony-forming units that you ingest, and possibly working on a healthy microbiome and reducing inflammation in your digestive tract, wouldn't that be preferable than taking any of these drugs for life? That all they're doing is just reducing inflammation and could set you up for more problems. I mean, when you're taking biological drugs, they can, some of them have been linked to eventually leading to cancer because they tie the body's immune system, hands behind its back to be able to normally, reduce those cancerous cells that we all have in our body at a given point, given time. So, you're taking these drugs, and what cost is going to eventually going to happen because of it?
Yeah, I have another theory on that too. Is that it's been shown that when you have dysbiosis and you have an increase in MAP and it starts to spread, you have a decrease in firmicutes, which creates its own set of problems. And so, like, you really alter the microbiome, and there have been different bacteria that have been associated with colon cancer and things like that. So, I think that the shift in the microbiome has a lot to do with that as
Oh
well.
yeah. Oh yeah. I mean, they say that it's the same thing that happens in Johne's disease happens in ulcerative colitis and Crohn's disease, and that majority of these people who've come down with these conditions, they possibly had compromised immune systems as a child, and even the animals, and they were exposed to these mycobacterium formed colonies in their digestive tract, and the disease doesn't manifest itself generally until young adulthood, which is what you see in both the animals and that you see in human beings. So, were you aware of that, Jason? There seems to be a huge correlation between what disease that you come down with and the age of the infection and the amount of the infection of colony forming units that you're dosed with.
I've read some studies that go over that for sure. I find those really interesting, and I think it's also interesting that, like, there's a different rate of diagnosis compared to males and
Yep.
females. Females seem to get IBD a lot more than males, and I have no idea why. Like, when they have IBD symptoms, they tend to have it in different ways. Like, it tends to present in different, especially with Crohn's disease. It seems to have males and females tend to have different, their lesions tend to be in different areas and they have different complications.
Yeah, and I mean, they say the more infection dose that you get can also determine whether or not what disease you get. Also, depending on your genes too as well. So if you get a small dose, you may get ulcerative colitis. If you get a large dose, you may get Crohn's disease. And also when you get it, for example, adults generally, if they do get a dose and you are an adult and you haven't had a dose to MAP, or your body's been able to fight it off, because just like it says in many of the studies, just because you're exposed to a microorganism, it may never cause you illness. A lot of us are walking around with Mycobacterium avium paratuberculosis within our digestive tracts to some degree.
I would say most of us probably are.
Yeah, so just because it's there doesn't mean that anything could ever come of it. And sometimes, it depends on genetic weaknesses. Sometimes it depends on epigenetical changes. Sometimes it depends on changes of microbiome that allow MAP to become dominant, like you said, a reduction of firmicutes. But yeah, if you get affected as an adult, you tend to develop ulcerative colitis. Where if you got infected as a child, you tend to eventually develop Crohn's disease in your young to middle adulthood.
Just for me, just trying to understand the genetics is difficult enough. And then when I start to look at the layer above, or the epigenetics, or how genes are expressed, because not every gene in the body is expressed all the time. That would be crazy, if all the genes are being expressed all the time. So genes have certain activators, certain promoters, and then they have certain restrictors. So there's a reason why a gene would be expressed or not. And we're looking at the different alleles and the different sections of expression of interleukins, part of the immune system that's put into effect by the expression of these genes. Is there a layer above that's interfering with it, or is it entirely genetic? Is it just entirely like you have non-functioning genes because of a polymorphism or something? Your parents, they had a gene that was transcribed incorrectly, and it got passed down to you, and now you don't express a certain gene the same way or something. So, for that, it just gets really complicated in trying to figure out the genetic layer of this and the epigenetic layer versus the bacterial infection. Why are some people more susceptible to it than others? Well, it's definitely corollary to genes. I think everybody probably has MAP in their body. I can't see how you would live to the age of like 4 or 5 before you come across that. And then, once you get any kind of species of bacteria in your gut, I think it's pretty much nearly impossible to completely eradicate.
Yes, I agree 100%. Like if you got H. pylori, even if you test positive after you've gone through eradication methods, it's probably still there. The colony forming units are just low enough where it becomes asymptomatic. But it would be similar. It'd be similar to MAP and ulcerative colitis and Crohn's disease. And there've been studies too, like the study of Crohn's disease is done in 2 French families, where it is shown that families are more susceptible genetically to both Crohn's disease and ulcerative colitis. But the reason why they think that it has a link in MAP is that those families still developed. Some of the children developed ulcerative colitis, some of the children developed Crohn's disease, but also families that have no genetic link together whatsoever, like mother and father, or like me, and like let's say that myself, I lived here in my house with my wife, and a friend of ours was staying here with us too. It goes to just non-genes as well, of people in close proximity also getting the disease too. They call it sporadic disease versus familial disease. So if you think that people who live in the same household but they're not related, how can they come down with the same disease? And more than likely, it does have to have some sort of microbiological origin. You would agree with me to that, Jason, right?
Yeah, I mean, there's an environmental cause, and then there's a genetic cause, and so basically any infectious disease is going to have an environmental cause because you have to be able to pick up the infection. But what they're proposing is this is sort of a combination between infectious disease and having a genetic link to it also. Now, could the person who's staying in your house also have a genetic weakness to the MAP bacterium, and then they're just not as exposed to it as much as they are, eating the same food and drinking the same water that they're drinking at your house? That's kind of where we run into the thing. The other thing that I wanted to mention is it's not just your genes, but it's also the genes of the microbacteria themselves. So, and sort of their epigenetics, or the layer above their genetics. So they can pick up certain genes that can make them more viralized, make them more pathogenic, I suppose. And then they express those genes differently when they're greater than numbers and they start to colonize. I think in our first podcast, we were kind of talking about this a little bit with H. pylori and sort of how the numbers make a big difference. So if you reach high enough levels of MAP, then the endotoxins, or these are compounds, lipopolysaccharide compounds that they express, do a lot of damage to the tissues, and they kind of start to suppress our immune system and make it a lot worse. So, yeah, I mean, there's, long story short, yes, that like the environmental causes like definitely have to be there. Genetics, I think, play a big role, but you have to be exposed to the bacteria, yes. But then on the other hand, like we're all exposed to it. So what's the difference? Well, people who are exposed to more MAP, that probably makes a difference. And then people who have a genetic predisposition to the disease, they probably suffer from it even more. So there you go. Complicated answer, but yes,
I mean, we know that Mycobacterium tuberculosis can produce necrosis-inducing toxins, many different toxins. They're neither gram-negative or gram-positive. You cannot stain them. They're unknown, to my knowledge, to contain endotoxins within their cell wall. But they are able to produce toxins like most organisms are. So yes, they definitely can cause a lot of issues. And Jason, do you mind if I talk about 2 case studies of people that I've coached?
Well, it depends. It depends with. Oh, okay. Yeah, that's fine.
So first off, the first gentleman has allowed me to use his name. He's a very personal friend of mine. His name's Thomas Quackenbush. He suffered from Crohn's disease. He was a friend of my. His son was a friend of my son, who met in elementary school, and we became friends. And I started coaching him to help him with his Crohn's disease that he was suffering from. He was still taking 5-ASA. He was not on any biological agents, and he was still having occasional bleeding, systemic manifestations of brain fog, chronic fatigue, and joint pain. I got him to give up all ruminant animal products, and we'll talk about what those ruminant animal products are when we discuss diet later on, and got him to start supplementing with curcumin and magnesium and boswellia and fish oil. And his disease, and he eventually stopped taking 5-ASA, and his Crohn's disease went into complete remission. All of those symptoms were completely gone. Here recently, he installed a reverse osmosis filter within his house, and completely cleaned up his water intake the best he can to decrease MAP ingestion. And he's felt the best he's ever felt in his entire life at this point. So I think his condition is a success. I would say that his Crohn's disease is in remission. Another person I knew was my son's physical therapist. He had ulcerative colitis. When I first met him, he was helping my son with range of motion type exercises, and he was taking 5-ASA. He was about to be switched to Humira, and he was being evaluated at UNC Chapel Hill and had severe bleeding to the point where they were considering taking out a few parts of his colon. I told him to immediately give up all ruminant animal products and to start using curcumin, boswellia extract, and CBD oil to reduce the inflammation. And he did both. And as far as I know now, he is off all medications for ulcerative colitis, as well as it has gone in complete remission in a period it took about 6 months for that to happen. And he has not had a flare up as long as he avoids all ruminant animal products. He has ingested ruminant animal products from time to time on special occasions, and noticed that as soon as he does it, it does trigger a flare up in his ulcerative colitis. But as long as he avoids them, he is in remission and seems to be doing well. And he lost no parts of his colon.
Have you ever run across a case where someone has been able to go into complete remission from either Crohn's disease or ulcerative colitis without dietary intervention?
No.
Well, there you have it.
And I've known people, sadly, that there have been some people that had such compromised immune systems and such MAP dysbiosis that even treating it with conventional antibiotics sadly got them nowhere. It's a very complicated disease, but there have been a lot of people who I've coached who have gone into remission, especially the 2 people that I've mentioned. They're very close people to me in my own personal life. When we talk about diet and we talk about supplements and treatments, conventional treatments for MAP that I do recommend, we'll talk about, why they do help and everything. But yeah, I mean, if anybody's listening, one thing that you can do that doesn't cost you really anything is just to give up ruminant animal products.
So what exactly can't you eat?
So it seems the diet that you have to do is you have to give up all ruminant animal meat and dairy. So you need to avoid the meat and dairy of cattle, goats, sheep, deer, any type of like wild game, camel, any of those. They contain Mycobacterium Avium Paratuberculosis. So you'd have to completely eliminate them from your diet, and you may not ever be able to eat them again. I've had a few clients get by with a well-done steak, grass-fed steak organic on occasion, but even then I would not recommend it. You are able to eat poultry. Now, Jason did caution wild poultry, which, the Mycobacterium avium paratuberculosis is found in those animals, but it seems not to be the same subspecies that causes ulcerative colitis and Crohn's disease. So it seems not to trigger. For example, both Tom, the physical therapist, both of them were able to eat chicken and turkey and duck. But there is a possibility that some of them are so severe they would not be able to tolerate poultry, and their only source of meat would have to be seafood. MAP has not been found, and to my knowledge at all, in any wild caught seafood in the ocean. So,
I don't think it's been found in pork either.
It's not been found in pork, no. Not
Okay.
yet. So you are able to eat pork as well. And my friend Tom, for some reason, he reacts negatively to pork, but the other gentleman, the physical therapist, he does not. And I don't know why that is. But yes, most people with ulcerative colitis and Crohn's disease are able to ingest pork as well.
My issue with the poultry, so you have wild game and they just fly around all over the place, right? So they fly over a farm and they land in sort of a local pond where the cows are using it as a water source, but the cows are all over the area, so they're pooping all over the place, and it rains and it gets into the water. Well, then you got a bird that goes in there, gets infected, and then flies to somebody else's farm, and then it infects their cattle, and it can infect other poultry farms too, because they can go over and, like, if you have, it's really, if you're keeping any sort of chickens or ducks or whatever, it's very important that you change out the water and clean the water troughs frequently, because what'll happen is, the outside wildlife will come in and contaminate that water source. So if you've got like a small dug-in reservoir where the water's collecting, well, your birds are probably going to get sick. And so it's better to change them out, because they're all in such close proximity, So that's, I guess, my issue with, I guess, how the birds are interacting and all this.
Yeah, I mean, it's a possibility that it could trigger it in some people, but for most people that I've coached, and most people I've seen, they're able to, especially if you're eating farmed, raised poultry, maybe if you want to go with organic for a little bit healthy, but yeah, it doesn't seem to cause any problems.
Okay.
Now, so that means, first of all, there are a couple of things I want to go back to. That is ruminant animal dairy. It doesn't matter if it's pasteurized or not. Actually, raw dairy would contain more MAP from an affected animal than pasteurized, but pasteurized still does not reduce it enough. Even flash pasteurization, high temperature pasteurization, does not reduce it enough for it to cause issues. You have to more than likely give it up permanently for the rest of your life. Also, like I mentioned, freezing. You can freeze ice cream up to a year, and if MAP is still in those fat globules within the ice cream, you will not kill it off. So you're more likely, if you're going to ingest ice cream, which I love ice cream just like everybody else, you're probably going to need to stick with coconut milk ice cream or cashew milk.
MAP seems to do pretty well with long chain fatty acids. So yeah, it does really well in butter and ghee. So I've looked at some studies in the difference in treatment of Crohn's disease and ulcerative colitis with antibiotics, and there are not very many antibiotics that are effective in the treatment of either of these diseases. No. And with ulcerative colitis, it seems hardly manageable with antibiotics of any kind. With Crohn's disease, you can use a long-term antibiotic if it's powerful enough. It has an effect, but you're going to be on antibiotics for
6 months to a year, and you're going to use rifabutin.
Yeah.
Mainly is the drug that's been shown in phase 3 clinical trials and studies for MAP. So they are using rifabutin as one of the main, because you use rifabutin for any type of tuberculosis condition. So yeah, they're using rifabutin, which, Xifaxan they all form in that same family. Rifaximin, rifabutin, and rifapin. And rifapin has a lot of side effects. Rifabutin, not as much. And Xifaxan has hardly any at all, because it doesn't. But the problem with Xifaxan may work for Crohn's disease if your issue is MAP of the ileum, but it will not work for ulcerative colitis because it won't work outside of the small intestine. So yeah, most of the time, what I've seen for drugs, you're usually giving rifabutin for anti-MAP therapy for 6 months to a year, and I've had 1 or 2 clients who have done that with differing success.
But you're saying you said rifaximin will treat MAP?
It's in the same family of drugs. Yes, it would work within the small intestine only. They have looked at it as being a potential use for Crohn's disease within the MAP therapy. Usually they use clarithromycin, sulfasamine, and rifabutin for Crohn's disease, but they were also looking at Xifaxan because it would work on the ileum, because they all come from the same class of antibiotics. All of them are in the rifamycin family of medications.
Okay, that's interesting. Definitely like to see more on that for sure. Other treatments they've looked at treating both forms of IBD with cannabidiol or CBD, which I found to be interesting because it binds to the CB1 and CB2 receptor sites, reducing inflammation. I don't know, however, if it would be completely effective. And I guess it works kind of in the same, when they're using corticosteroids or glucocorticoids to treat this stuff, yes, it does knock down the inflammation, but it's also, you got to understand what inflammation actually is. Okay. And a lot of people don't understand that. They think inflammation is like, oh, that just must be swelling. Like I bonked my knee. Sorry, I'm talking to you guys like I'm talking to a 3-year-old. You injure your knee and it swells up. That's inflammation. Okay, yes, it is. But there are many other types of inflammation that don't cause swelling. Inflammation is just a reaction from the immune system. Okay, it's the expression of interleukins and cytokines. So that's what the inflammation is. So the glucocorticoids are acting as an immunosuppressant. Okay, CBD comes in and it works differently to suppress it uses differently to suppress inflammation by binding the CB1, CB2 receptor sites. So it's more of a localized, more of a targeted immunosuppressant.
It kind of wakes the immune system up and say, hey, do what it's kind of properly regulates it, right? It kind of gets it to not overreact or underreact, but kind of modulates it so it reacts. Because inflammation in itself is not bad. You need it. If like, for example, if you got a cut and the cut there's no inflammatory response, you would never heal.
Right, because it's like IL-6 is going to be expressed, and then then the tissues are going to be healed up. Like if you shut down all the inflammation in the body, you'd be dead. But we're specifically looking at like ICAM1 and VCAM1 surface expression of the epithelium. That's kind of technical, but it's like we're looking at how to reduce certain expression of the immune system while not interfering with all of it. Whereas the corticosteroids, the glucocorticoids, are going to have a much broader, effect, just like, kind of like treating something with a broad scale antibiotic rather than a targeted antibiotic, or, same thing.
Just like curcumin being a reversible COX-2 inhibitor, where aspirin is a permanent, within its half-life COX-2 inhibitor. So use of curcumin is a little bit safer.
Yeah, for sure. Yeah, especially with the the bleeding and the GI, it seems to be a lot less stressful on the gastrointestinal tract. But I still, every time we bring up curcumin, the studies that have been done on curcumin with success are the liposomal forms of curcumin, not the just regular
yes, they have to be phospholipid.
Yeah, not just like eating a bunch of turmeric, which is still good. It still has a localized effect, but the stomach acids really break down the curcumin and turmeric really quickly. And so the studies that have been done on curcumin and reducing inflammation, they have been done on liposomal forms of curcumin. So it's important to get that. They're more expensive, but they're tried and true. They're tested.
And there hasn't been a lot of study on the effects of natural herbal agents against Mycobacterium. But it is a possibility that curcumin and boswellia may have a direct effect on MAP itself, because both herbs contain antimicrobial polyphenols.
Yeah, I hadn't considered that.
And also, one quick thing I wanted to mention too when we're talking about the immune system is most people with Crohn's disease usually are suffering from Th1 dominance or Th17 dominance, or most people with ulcerative colitis are suffering from Th2 dominance. It might just be how the genes may be different, showing their expressions of interleukins and cytokines. But yeah, especially with someone with Crohn's disease, curcumin would work very well. Or someone with ulcerative colitis, it may not work as well because Th1 dominance is not expressed in someone with ulcerative colitis generally.
Yeah, with that, I kind of wonder if that's a chicken or the egg thing too. I mean, does it show up as ulcerative colitis because they're Th2 dominant, or does it show up at Crohn's disease because they're Th17 dominant? Like, I don't really know. And so
now CBD oil should help both.
Yeah, for sure. Probably the Th17 more than the Th2, but you're right. It should help both. It should have some help with ulcerative colitis as well. So for that to work, probably the best way is to get decarboxylated version of cannabidiol and ingest it, either in a capsule or something like that.
Yeah, and there's a MAP protocol within Fix Your Gut with certain herbs that you can try to find relief and reduce the. Because some people do get remission just by giving up ruminant animal products and cleaning up their water, which we forgot to talk about water too. I guess we should talk about that real quick.
Yeah, I forgot to talk about the water.
Yeah, I mean, there are some natural herbs that you can try to take to reduce the MAP quality forming units. Hopefully, we mentioned curcumin as boswellia. Those are both been studied specifically for inflammatory bowel disease and their positive abilities to help both the microbiome and the immune system when it comes to people suffering from those disorders. But yeah, I mean, there are other things possibly like cinnamon oil and or allicin or berberine, and may have anti-MAP effects. MAP are also able to produce thick biofilms. Now, generally with MAP, I don't recommend the ingestion of colostrum, even if you're suffering from ulcerative colitis, which would help modulate the Th2 immune system because of its source of cattle. But you would to bust up biofilms, it actually might be a good idea if you don't have any mercury amalgams to actually use NaC, because MAP is systemic in most cases. And you want to use no more than 1,200 milligrams of NaC a day as a biofilm buster, or a gefniacin. Either one would work systemically to work against, because MAP are able to produce very hardy biofilms. They're not able to produce endospores. They're not endospore formers, but they are biofilm formers. And when it comes to water, since they do colonize very easily municipal water supply pipes and can get it from farm runoff, I would recommend that most people with MAP buy a whole house filtration system, and underneath their sink, they should use reverse osmosis or have a countertop distillation to distill their drinking water to get it the cleanest they possibly can, in the hope that you don't ingest any MAP.
Yeah, I think they should probably avoid bottled water too, because it's been shown that bottled water has greater instances of MAP than tap water, because it sits in there for a while. Even if it's reverse osmosis, if it can become contaminated, you're in trouble. So there's like there are countertop RO machines.
Yes, I have one.
You don't have to get the full plumbing job. Yeah. You don't have to get the full plumbing job, and you can get a fairly cost-effective plan. But I mean, if you end up like being diagnosed with IBD, you might want to just go ahead and have an RO system put in your house, reverse osmosis system put in your house, just because you're going to be drinking a lot of that, and you can't go back to tap water after that.
And you also want to make sure too that you, like I said, do whole house filter, or if you can't, do a shower filter, because you do not want to breathe in aerosol MAP.
Oh, yeah, for sure. Okay, so I want to go back to that topic on biofilm. Now, there are other biofilm busters out there. Would you recommend something like Interface or Interface Plus?
Yes.
Okay.
Interface Plus, as long as they don't have mercury burden or mercury amalgams, the use of EDTA would work.
Okay. Well, they have. Okay, so the difference between Interface and Interface Plus is the EDTA. Yes. So Interface Plus has the EDTA. If you have an issue with mercury, you can just go with the Interface, which doesn't have EDTA in it, and you just get the enzymes that break down it's like a collection of all kinds of stuff. I forget how many are in there, but we're really fortunate because Claire Labs decided that they were going to be prescription only for a long time, and then they finally got back on the market. They were like, I guess we'll sell to everybody again. And I don't know how many times I was in contact with them. Just my belief is that everybody should have access to this, because it's really valuable, and they shouldn't have to get permission to use a supplement that would help them. They shouldn't have to go to a doctor and get a permission slip. I think people can make those decisions for themselves, and I really don't think that they're very dangerous on their own. Interface Plus can be a little trickier if you have a mercury burden of some kind, but still, I mean, it doesn't have that much EDTA.
Yeah, and Interface itself, as you'd mentioned, my only problem with it is the EDTA would work systemically. I'm not so sure about the systemic enzymes and breaking down the biofilm. You've written about that on Fix Your Gut.
Well, I'm not sure about this. Well, the systemic use of EDTA is when it's used in an IV and not when it's ingested. So I'm not so sure about that. I would just recommend Interface and not go with Interface Plus because here's the other issue with both Crohn's disease and ulcerative colitis is that people tend to have deficiencies in anemia anyway, and EDTA is an iron
Mm-hmm.
binder. So in the gut, when you take it orally, it might bind the iron, making it less bioavailable. So I don't know and there's another argument that'll make it more bioavailable, but I would stay away from that in general.
What about the
Anyway,
use of lactoferrin because of its dairy source?
I don't know.
Yeah.
That's a good question. I mean, if you're saying no colostrum, I would say no lactoferrin. And I think pretty much the most valuable part of the colostrum is the lactoferrin, in my opinion. I think the rest is marketing. But the lactoferrin, I don't know. Like I wouldn't be comfortable recommending it just because I don't know the answer to that.
Yeah, and also one thing about diet is you want to make sure that you avoid carrageenan in the brown seaweed extract. That's been implicated in
Mm,
causing bowel inflammation. Even most people in your general health, if you feel healthy, should avoid it.
yeah, you don't want it. Yeah, I mean, it's been linked to cancer, and you want
Yeah,
to
but
stay
it's a
away from it. But
thickener.
also, yeah, that's true. You also want to avoid. Do we talk about like whey protein and collagen proteins yet?
No, I don't think we. I don't think we talk. Yeah, that was the next thing that we need to talk about is if your whey pro. You should avoid ruminant animal protein, whey protein, whether it's from goat or cattle source, and you should also avoid collagen protein that is bovine sourced. You can ingest possibly chicken collagen, fish collagen would probably be the best way to go. I guess you would probably agree with me on that, Jason.
Yeah, but for some people, the fish collagen really, like if they have any kind of SIBO or dysbiosis, it can really wreck
Yeah,
them because bacteria seem to really enjoy that.
it's good for bifido though.
Yeah, collagen's almost like a prebiotic on its own. So yeah, it's interesting. On that track, though, I've looked at studies of using prebiotics and probiotics in IBD, and they don't seem to be very
No.
effective.
What about since you reduction of firmicutes, why not eating a diet that would help increase firmicutes? Like, for lactobacillus, you
Like
could eat
beans.
ferments like kimchi or sauerkraut. And to increase rosaberia and a lot of your firmicutes, you could eat organic, non-iron fortified oats or walnuts or something like that to try to increase the firmicutes by feeding them.
Yeah, I don't know if that'll help until the map is gone.
Or reduced,
Um,
yes.
or yeah, it's not going to be. That's a better way of saying it. They're never going to be gone. But yeah, until you knock them down to normal numbers. I mean, I would think you should focus on that first, and then I don't think that rebuilding the firmicutes are going to solve the mat problem. I think you're going to have to solve the mat problem and then rebuild your firmicutes, which is a phylum that extends to a lot of different species of whatever. So anyway, yeah. Well, I guess anything else you want to say before we wrap this up?
Yeah, one last thing is the use of N-acetylglucosamine, as long as you don't have a candida secondary overgrowth or dysbiosis with MAP, has been shown greatly to reduce inflammation in people with inflammatory bowel disease and help feed the
Mhm.
gut, help pretty much with the gut mucosal lining repair. And you might be able to get away with the use of glutamine as long as the glutamine, as long as you don't have any secondary dysbiosis with MAP that lives in the upper gut, because MAP, from my knowledge, from my research, from my literature, it doesn't really colonize above the duodenum, right?
I don't know that for sure, but it seems right.
So yeah, you should be able to tolerate, in theory, L-glutamine then.
I would think. I don't know. I don't know for sure. Also, yeah, for wound healing, cannabinoids seem to work pretty well for that too, for repairing ulcers in the anything south of the duodenum. Yeah.
Yeah, and zinc carnosine should be relatively okay to take too. Now, the sufficiency past really the duodenum would be not that much, but yeah, but definitely if you have ulcerative colitis and Crohn's disease, one of the easiest things that you can do is just try to clean up your water as much as you possibly can and avoid ruminant animal products and see if that makes a difference in your health.
Yeah, that's probably the only way to go. Everything else, I think, is going to be secondary to diet, just from all the case studies that have been out there. I mean, there are people that have tried different interventions for years and have gotten a little bit of relief, but really nothing manageable. So yeah, just the change in diet is going to have to be a permanent thing.
Now, if you're really anal about your water supply, you can get some of those filtration straws that they have, or you can use to drink from rivers and not get microbes from ingesting from those sources. You could take that and use that to drink your liquids or bring filtered water from home. But if you're on a vacation, that's not necessarily possible. But you could use those straws to clean up the water supply if you went on vacation or whatever, so that you would not get ill.
Yeah, I mean, I guess it depends on how long you're going to be on vacation. But I mean, with the water, you're not going to run into as many. It's not going to be as a big a source as with like milk or
milk.
With steak.
Yes.
So,
milk is the biggest source, other than living next to a farm, cattle farm.
Yeah, you're getting the MAP, and you're getting. We didn't talk about this either, but you're getting a protein interaction that could be harmful. But anyway, I guess we'll just wrap it up there. We could keep going on forever, but we gotta call it quits. So I hope people got some good information. We'll put some stuff. Let's make sure that we put the link to the article on MAP and the from fixyourgut.com in there, so people can get some help if they've got it. And thanks everybody for listening.